Hello everyone, my name is Badri Thiruvenkatachari. I'm a professor in orthodontics at Sree Balaji Dental College, and I'm also the lead orthodontist at Sree Balaji Medical College and Rella Hospital, a part of Smile Train Cleft Lip and Palate Center. Today's discussion, I'm going to be talking about cleft lip and palate in general and the orthodontic treatment related to patients with cleft lip and palate. This is going to be a generalized overview of what we see in clinical care in the orthodontic department. I'm also going to be talking about the etiology, a classification of the cleft lip and palate. We'll talk about different treatment pathways and the different treatments we offer for patients with cleft lip and palate in our department. And we'll give you a final summary of what we've discussed and close it up. There are some photographs that I'm going to start off with showing you about patients with cleft lip and palate. This is MH, one of my favorite patients. She has a unilateral complete cleft lip and palate. You can see that her scar on the right hand side of the upper lip. There is also the upper right incisor that is being sucked into the cleft region, which is typical for patients with cleft lip and palate. The second patient you're going to see is GH. He is an 11-year-old boy, a beautiful looking boy. He has bilateral cleft lip and palate. He's had some surgeries soon after birth, but he's going to have few more surgeries in another 6 months to 1 year. He has a bilateral cleft with the premaxilla being pushed forwards and towards one side. So the premaxilla has 4 incisors. In his case, he has only 2 incisors, that's the central incisors. And my third patient, I could say that he's one of my most favorite ones in my dental practice. So he has a bilateral cleft lip and palate, but much more severe in terms of the projecting premaxilla. He's slightly older, he's 12 years of age. He's got a lot of orthodontics to do for him and a few surgeries as well. The last one is a patient with just the cleft palate. She's got no cleft lip and no alveolus. It is just the palate that's been operated. At this point, she looks as if she's got no cleft. But you can see a tiny fistula towards the end of the hard palate. So these are some of the patients that we see routinely in clinical care. So why these? I'm going to give you an idea of what these patients undergo, how we treat them, what we do for them from 0 to 18 years. The beauty of working in cleft lip and palate with these patients is that you start off as soon as after birth and you go through their life with them until 18 years of age. We, as orthodontists, are the lucky ones to see them grow from birth till 18 years of age and then they discharge. Usually they become our family. We know them really well because there's around 3 to 4 courses of orthodontic treatment, with each course lasting about 1 to 2 years of treatment time. So they become our big friends and we carry on with them for the first 18 years and beyond. Let's go into some theory. I know it's boring, but we have to start with some theory of cleft lip and palate. You need to know the basics of cleft lip and palate so you understand the patients better. We have a huge number. 1 in 700 newborns is the count worldwide. It does have a huge geographical variation. The least is the Afro-Caribbeans, Caucasians, reasonably high, and Indian population, it is quite high. There is also an unfortunate tendency for these anomalies to happen in low socioeconomic patients. And there is a variation in the economy of the patient as well. We don't know why, but it does happen. To put it in real world scenario, there is 1 patient with cleft lip and palate born every 2 minutes in the world. That's a really high number. The Indian scenario, really vague. We don't have any statistics for Indian scenario. We have some guesstimates, some local research in regional areas, but there's no national database for cleft lip and palate, so we wouldn't know the full number. But approximately, with the mathematical calculation, we could say we probably have around 27,000 to 33,000 babies born with cleft lip and palate every year in India. Again, that's a guesstimate. I hope it's a good guess, but it's a really high number, of which there's around 22,000 patients with cleft lip and palate, and there's around 4,000 patients with cleft palate alone. They're completely different. We'll talk about that in a minute. And 3 every hour in India alone, which is a high number. The sad part of India is that a lot of these patients don't have access to care. A research done around a decade ago, like 2010, showed that 19% of these patients born in India don't have access to care. That's a terrible number, but things have improved quite dramatically in the last decade. So I'm hoping that the number should be much, much less than what it says in 2010. Boys, unfortunately, are more frequently affected with a 2:1 ratio. This is the frequency. Asians are more prone than the Caucasians, than the Afro-Caribbeans. As I told earlier, Afro-Caribbeans are the least affected. For some reason, which we still don't know, it's a holy grail, a mystery that we are trying to find out why. It happens more frequently on the left than on the right-hand side, with a good 2:1 ratio of more on the left compared to the right. It is one of the most common congenital anomaly. 38% of those who have cleft lip and palate have some other congenital anomaly associated with it. The most common is the stickler. The other first branchial arch syndromes like the Treacher-Collins, Pitt-Robons, and so on are quite common to associate with cleft lip and palate. So a patient with cleft lip and palate, you do have to make sure that they are not having any associated syndromes, because the whole treatment is then put into a different level if they have additional syndromes associated with cleft lip and palate. Of course, the pediatrician will assess as soon after birth. Sometimes the anomaly scan done at 20 weeks of life will tell us whether they have any associated anomaly or not. If it does tell us, then it's much easier for the patient and for us to prepare the patient for what treatment they need soon after birth. Cleft palate, the isolated cleft palate, are a different breed. They are completely different from cleft lip and palate. They are genetically different. Their incidence is different, is 1 in 2,500 newborns worldwide, as opposed to 1 in 700 with cleft lip and palate. And females are more commonly affected than males. That's an interesting finding with no reason why this happens. They're also associated with congenital anomalies, slightly higher compared to your CLP. So a patient with a cleft palate alone have to be really looked into whether they have any associated anomaly or not. There are different associated anomaly with cleft lip and palate, and with cleft palate alone as well. One of the most common is the congenital heart defect. So congenital heart defect is one of the most common anomaly that comes with cleft lip and palate. So any baby that's born with CLP will be looked at by a pediatrician and a cardiologist, if need be, to check for any cardiac anomalies associated with it. And most of the patients who have associated first branchial arch syndrome also have micrognathia, small mandible. There are associated congenital hydrocephalus and ectopic kidneys and so on, but the incidence is much less compared to the associated heart disease or micrognathia. Why does this happen? Why these poor things have cleft lip and palate? It's really unfortunate that they have cleft lip and palate, but we also need to know why this happens. Well, I'm going to go into a bit of anatomy. Of course, for first year undergraduate, they might be much more knowledgeable than myself in terms of anatomy. So there is the median nasal process and the lateral nasal process, along with the maxillary process. All are derivatives of the first branchial arch. The medial nasal process and the lateral nasal process kicks out the frontonasal process, which is right in the middle. So the frontal-parenasal process, which is shown by the brown middle part, goes back. And why does this happen? It is very unfortunate that these things happen for our patients, but we also need to know why this happens. So we are going back to first year undergraduate anatomy. I bet the first years know much better than me, but let's just brush through our anatomy for a minute. So we have the frontonasal process, we have the medial nasal process and the lateral nasal processes. All these processes combine to give you the full face. In the second row of pictures, or second column of pictures, you see the top one has the middle brown section. That middle brown section is the frontonasal process. And then the green one adjacent to it is the medial nasal process, and the blue one next to it is the lateral nasal process. The purple ones on either side are the maxillary process. You can also see that the picture on the bottom half shows the maxillary process as two halves. In an ideal child, the frontonasal process kicks back. It's being pushed out backwards by the medial and the lateral nasal processes. So those two processes come and merge together, kicking back the frontonasal process. And then the maxillary process then merges with the fronto and the medial nasal process. So they all combine together. The maxillary process at the back of the nasopalatal foramen, which you see in the picture down in the bottom, the third column, fuses together, the right and left side fuses together to form one maxillary arch. So any failure of the fusion gives rise to a cleft. So the medial nasal process fails to fuse with the maxillary process, will then give rise to cleft lip and cleft alveolus. The failure of fusion of the two maxillary processes on the posterior side will then give you the cleft palate, the hard and the soft palate. So any problems, any disintegration or any difficulties with this face will then give rise to cleft lip and palate. So why do we know this, and what is the advantage of knowing this? Right, we know it just for knowledge. There is nothing that can be done if you find out that this is happening. You just have to wait and watch. The one advantage of knowing this is that we do an anomaly scan at 20 months of age. In that scan, if you pick it up, then parents can be advised of the babies that they're going to give, saying that they may have cleft lip and palate, and they get prepared for it. So the first thing we do, we have a psychological counseling for these patients, or for the parents who have a child with cleft lip and palate in the womb. So we have a psychological counseling, and bear in mind, this is an aesthetic anomaly. Right? This is not life-threatening for the baby. It is just a defect that can be cured. Aesthetically, that can be cured. The baby can be a normal baby, a normal child for the rest of their life. So there is nothing worrying about apart from the burden of care that they have to undergo. The child can be treated and given a good aesthetic face so they can be a normal child for the rest of their life. So that's the counseling that happens when they diagnose it in the 20-month scan. Now let's move on to the types of cleft lip and palate. We briefly touched about the CLP, cleft lip and palate, and the cleft palate on its own. But now we're going into slightly deeper into the different types of cleft lip and palate. So I have different faces, and I'm going to go through one by one. On the left, you have a child with normal face. No cleft lip, no palate, no alveolus. Absolutely normal. So on the second one, you have a patient with a cleft lip. This can be accompanied with an alveolus or without an alveolus. So the picture shows a cleft of the upper lip on the left-hand side of the patient. The third one is a diagrammatic representation of a patient with a complete cleft lip, alveolus, hard palate, and soft palate. The entire middle segment is not glued in, is not fused together. So there is an entire cleft lip and palate. Complete, we call it, cleft lip and palate for the child. The fourth one is a bilateral cleft lip and palate. So the baby has lip on both sides, alveolus on both sides, and then it merges like a Y in the nasopalatine region, and then they get a midline cleft all the way through in the hard and the soft palate. The fifth one is a patient with just the cleft palate on their own. So there's no lip, there's no palate, there's no alveolus, but they have a midline cleft on the hard palate. It can be just the hard palate or it can be hard and soft palate. Now you know the different types of cleft lip and palate. Now let's jump into the etiology. We're always curious to know why, not just we, the patients even more. They're curious, they want to know the answer. The first question that comes to their mind when they see the baby is, why has this happened and why me? These are the two questions that haunt all the parents who have got babies with cleft lip and palate. But unfortunately, technology is improved, we update our knowledge as doctors, as clinicians. Nothing can give us the answer. Nothing can give us the answer to say why this happens. We can correlate these patients with some genes. The genes are enormous. There's so many genes that can be correlated. But there are some specific ones that might link to patients with cleft lip and palate. Again, these things change on a daily basis. You have some brilliant researchers coming in and saying it's completely wrong, there's something else in there. Or they might say there is some added gene. So we're still looking for the holy grail, for someone in this world to identify which gene is strongly associated with these patients. When we identify the gene, we can have a cure for them. But at this point, we don't know. Some of these genes are TBX1 and COL11A2. There are some more recent ones. There are specific genes that are associated with patients with cleft lip and palate alone, and there are specific genes that are associated with patients with congenital anomalies or associated syndromes and CLP. Van der Wood is one of the most common ones. They have RF6 gene that is associated with Van der Wood, and most of patients with Van der Wood also have cleft. So Van der Wood is nothing but, you would have seen patients with some pits on the lower lip. When we see patients with pits on the lower lip, then we'd say it's Van der Wood. Why do we know that? Why do we need to know that? It's very important because the treatment is different, they act in a different way, they're not the same as patients with cleft lip and palate. So you need to be a bit more careful and identify the associated syndromes with it. And the common one, the PRS, Peri-Robon syndrome, which is a first arch defect, is much associated with SOX9 genes. So they are much different. Peri-Robon are quite difficult to manage because of their micrognathia. They have, immediately after birth, they have difficulty in breathing because of the small sized mandible, and the tongue falls back, giving them difficulty in breathing. In severe cases, they may need tracheostomy soon after birth. Or sometimes they also need distraction of the mandible soon after birth. Some things that we do for these babies with PRS. Although genetic ones are very difficult for us to control, there are some environmental ones that we can control. Some environmental ones that have been associated with CLP. Smoking during pregnancy is a high correlation with patients with cleft lip and palate. Alcohol and parents who have babies at older age, greater than 40. With this day and world, we're all going behind our work commitment and leaving the family to the less priority group, and this will be one of the high risk indication for patients with cleft lip and palate. Folate deficiency, which might be controlled nowadays because every pregnant woman is now given with folate supplements to avoid folate deficiency during pregnancy. Zinc deficiency and diabetes in severe form could cause cleft lip and palate. There are some medications that can cause CLP. Valproic acid, phenytoin, given for convulsions given for seizures can cause CLP, and retinoic acids. Of course, pesticides, if taken inadvertently or advertently for some reason, can cause CLP. We are now moving on to classification. It amazes me with the number of classifications we have for these patients. There are hundreds. Everyone comes up with their own classification. But why do we need this many number of classifications? What does it give us? It's only for the ease of communication. It's only for the ease of the Cleft team and for global communication. So if you have a global classification, it's much easier to communicate into the global world. And also for research purpose. Some classifications are easier for research. Some classifications are easier for clinical communication. So it depends on the clinician's interest and clinicians' acceptability to different classification, and they adopt certain classifications in clinical care. I would simply say to my trainees and my consultant colleagues, the best classification is to explain it very clearly. Does the cleft involve lip, palate, or alveolus? Just say it out. Is it a complete or an incomplete? I'll talk about complete and incomplete in a minute. Is it unilateral or bilateral? If you can say every patient with these three definitions, then you're almost done with every classification that you have in the world. So this is the easiest way. The one that we use currently is the LaSalle classification. Really simple. It's a diagrammatic representation of the cleft lip and palate. It is seen as you see in the patient. The right-hand side is patient's right. The left-hand side is patient's left. Right? It's clearly marked for right and left, so there's no confusion in this. There is a capital L and a small l. So if a patient has a lip, then you mark it as a lip. A lip on the right, you mark it as a lip, mark it as L. Incomplete cleft. Incomplete cleft means that there is no communication from the oral to the nasal part. So if the cleft stops halfway, and if there is no communication, that is incomplete. But if the cleft runs through oral to the nasal cavity, then it is a complete classification. A complete cleft lip and palate. So it can be complete cleft lip or incomplete cleft lip, complete palate or incomplete palate, and so on. So if there is a complete separation of the both sides communicating with the nose, then it's a complete one. If it's a partial separation, then it's an incomplete one. Areas that are not affected in this classification are represented by just a dot. A dot means no cleft, nothing to worry. A capital L means complete cleft. A small a or L means an incomplete cleft. So L stands for lip, A for alveolus, H for hard palate, and S for soft palate. Shall we go through some examples? Right. So a complete bilateral, don't look at the picture yet. Don't look at the photograph of the patient that I put in. Don't look at it yet. We'll come back to it in a minute. If a patient has a complete bilateral cleft lip and palate, that's everything that you can see in a patient, then you mark it as LAHSAL. So lip complete, alveolus complete for the right hand side, hard palate complete, soft palate complete, that's midline, there is no right and left there. Then again going back to alveolus on the left complete, lip on the left complete. So you call it a LaSalle, a full complete bilateral cleft lip and palate. Right, now let's go to the picture. Right, complete left cleft lip, alveolus and palate. How do we grade it? Right, how are we going to grade this? It's only on the left hand side, nothing on the right hand side. Right, two dots to start with, which says, you can see that the Y on the top picture on the upper right, on the screen right, is right hand side lip and right hand side alveolus. So there is nothing. Right. There is a small error in it, but I'll come back to that error in a minute. There's nothing. And then the left hand side, you see there is a complete lip, alveolus, hard palate, and soft palate. Right? There's a complete on the left hand side. So you mark them as L capital, A capital, H capital, and S. Now, for those who are clever boys and girls who have spotted this, there is an error in this picture. The picture was intentionally given because I wanted to show you the difference between a complete and an incomplete. This boy, a really nice boy, we were following him up from the age of, from 20 weeks scan. We've been with the parent doing the counseling, and now he's around 4 years of age. I'll come back to him in this treatment in a minute. So he has an incomplete lip on the right hand side. If you watch it closely, he has an incomplete lip on the right hand side. So when he has an incomplete lip on the right hand side, what do? You can't put a dot. So I'll put a small L and then a dot because he does not have any alveolus. There is no alveolus of the cleft. Then you go on to the left hand side. Capital L, capital H, I'm just drawing it here, and a capital S. So it's a small L dot capital L, capital H, and capital A, capital H, and capital S. So left hand side remains the same. The right hand side, there is an incomplete lip. So can you see the difference in the complete lip and an incomplete lip? Complete on the left, incomplete on the right. So you can see the difference between incomplete and complete. And there is no alveolus cleft in the right hand side. So now looking at incomplete left cleft lip, this is what you're going to mark. There is nothing on the right, nothing on the left alveolus or palate or soft palate. You mark it as a small L at the end with 5 dots preceding the small L at the end. I hope that's clear. So it's a nice classification, simple way of telling your colleagues and patients and the global world that the patient has just the cleft lip that is complete, that is incomplete. Complete hard palate and incomplete soft palate. 2 dots at start, H capital, small s, 2 dots at the end. So this is how you notify a complete cleft hard palate and incomplete cleft soft palate. Now let's move on to treatment.